So this is integrated behavioral health in the primary care of children. I didn't say in pediatrics because people think that pediatrics is only done in pediatricians' offices, and it's done in family medicine as well. So we're talking about the primary care of children, although it is truly fair to say that most of the care of children is done in pediatricians' offices. This was also with the consultation of Barbara Ward Zimmerman, a person who is a consultant on pediatric primary care integration based in Connecticut, and who is well known in the field and whom I have known for a long time. So we're going to start with reminding, I'm assuming that there are one or two PCPs, physicians or nurse practitioners or PAs who work in pediatrics out there, but that the vast majority of the people that I'm talking to are either behavioral health clinicians or policy folks or trainers, that they are people who don't work in primary care. And so that's why we're going all the way back to the beginning here, just for a little bit of orientation and reminders. So what does the primary care provider do in healthcare of children? Well, starts with promoting health, both physical and social health. So prevention is a core mission. And therefore, because prevention is a core mission, a population is approach is a core mission. If somebody can go out to a school and say something about children's health that makes either parents or teachers or children take better care of themselves and be healthier, that's an excellent role for pediatrics, and many pediatricians and family doctors do exactly that as part of their population approach to caring for a panel of patients. There's also supporting the development of children by both monitoring the developmental trajectory and being early interventionist when someone sort of seems to be falling off the usual glide path of developmental trajectory. We're educating parents and other caretakers about kids and how to support their growth and their development. And then lastly, identifying and treating diseases of children and adolescents. So at the outset, I think it's important to say that integrating behavioral health into pediatrics is a bit different than just hiring a therapist. In fact, doctors who have hired a therapist to work in their practice, and this has happened a lot, the doc loves the idea of, I can't get my kids seen, the people I refer seen in the specialty services, so I'm going to hire my own person. Tends not to work. People who won't go to won't follow up on a therapy referral when it's done to specialty mental health will when the person's in the practice. And so the amount of folks who accept the referral is about double when the therapist is in the practice. But if this therapist is seeing people like they would in specialty mental health, seeing kids and families for longer periods of time, doing one-by-one approaches to making kids better as opposed to one-by-one and population approaches, very quickly their schedule gets completely booked. And so the doc, who was delighted and relieved when they brought in the therapist, pretty quickly, just a few months on average, is saying, now I have a 4-week waiting period in my own practice. What good is that? And so these arrangements often end very uncomfortably because it doesn't work commonly. And when I talked to Barbara Ward Zimmerman about this, she said she's seen it happen a lot in her work in Connecticut, and that not a single program that she knows about has stayed going, has worked. So the role of the behavioral health clinician in primary care is, in fact, the core mission is the mission of primary care. It's not different. So it is prevention, it is monitoring, it is population approaches, and it is, third, the treatment of, we won't say disease, we'll say perhaps disorder or concerns or problems, but we are in the same generalist approach as the docs, and with the addition that we have a second customer. We have two customers. One is the patient and family, and two is the docs and other staff in the practice. So our job is to offer behavioral health expertise to support all these folks, and to offer brief interventions for kids and families. Now, when you add a behavioral health clinician in primary care, it does open up what primary care can do, and in fact, help primary care for kids meet the recommendations that otherwise it's of the American Academy of Pediatrics, that otherwise it's very hard for them to meet. So it becomes possible to address postpartum depression, to see a mother or a family with or without the child. This is very hard for physicians to do. They can't offer treatment to the mom they're not used to it, and everybody doesn't expect it. Whereas if you have a behavioral health person, it becomes possible. Adolescent depression and anxiety, things that seem to go along with childhood anxiety and family stress, such as unexplained belly pain, or which sometimes develops into irritable bowel syndrome. Substance abuse, and screening for ACEs. We'll talk more about that. That's adverse childhood experiences, and SDOH is the social determinants of health. For that, most places would want to have a team, not only a behavioral health clinician, but also case or care management to be able to help people with their social situations. And it's important for us as behavioral health people to remember that these physicians or PCPs that we're working with have a lot of experience with behavioral health. Behavioral health did not become part of their job when we got there. We're there to help them with what they've been trying to do for a long time. It means that if we come in and say, no, this is how it's done, we're going to change the program here because I know about behavioral health and I'd like to have us do things differently. Sometimes that's a non-starter. And the best way to make it a fit for the physician and the other PCPs is to be aware of and to reference the requirements and the tools offered by the American Academy of Pediatrics, which does a fantastic job of creating tools and guidance for dealing with behavioral issues in pediatric care. This is the title of the sort of the largest of that kind of guidance. It's called Bright Futures, and it's available on the web as well as a book. It talks about the preventive tasks of each well child check. It gives tools for dealing with a great array of problems, a great array of family struggles, and how to orient families to certain pediatric problems. So you should, if you're going to be a behavioral health clinician in primary care, you should not only know about Bright Futures, you should review it, and you should use it whenever it's a fit, because that will be comfortable and will be something that makes that is familiar to your PCP colleagues. Here's the AAP screening recommendations. Notice it doesn't say depression or anxiety. It says developmental screening, screening for both for development up to 30 months, as well as screening for autism. We'll talk about how to do that in a little while. Screening for maternal depression, screening for the social determinants of health, asking people about food and housing and heat, and screening for family strengths. Let me underline that. You know, good on you, AAP, that they would steer us toward looking for strengths of the child and the family. And I'll talk a little more about that in just a second. We should remind ourselves of the special roles of parents in care. For small children, even many adolescents, but almost all small children, it's always a family visit. There's the parent and there's the child, and the parent is the one who needs to be influenced and needs to be heard in order to be, for the patient and physician interaction to go well. As children get older, both behavioral health folks and physicians get better at involving them and their parents in the interview, not just one or the other. But the parents stay a crucial factor, and doing things that might alienate them or that they don't, offering advice that they don't understand, means we haven't really done our job. And part of this is that we're, as parents, we're connected to how our child is doing and to other people's judgment about our child. So if our child is doing well, we're kind of proud, you know, feel like we're doing a good job. If the child has something wrong, even though intellectually we might know it's not a big deal or there was nothing we could do, that's not how most of us feel. We feel like we screwed up. We feel like, oh no, this is awful. And so a lot of the guidance that's part of well child checks that providers think of as just sort of factual questions, parents experience as being on trial. And so if you ask questions like, does he, do you use seatbelts? Or I'm trying to move my little square here, yeah, so that you can see that this picture, because the parent doesn't look all happy about these questions. So where are the cleaning fluids? In other words, did you remember so that your child won't be drinking the Clorox? Does anyone in the household smoke? Who cares for her when you're at work? Does she say any other words? How's she doing in school? Each of those, and these are just a small sample of the kinds of questions that get asked over the years. Each one of those can be something that a confident parent joins with the provider about. Yes, absolutely. Of course we do. Yes, tell us anything else we might need to know to keep her safe. But a not so confident parent, or a parent who isn't doing all the list, can feel on trial about. And when the parent feels on trial, they are less likely to take the advice of people who are trying to protect and support development. So you lose your ability to influence parents in as much as you alienate or put them on trial. You see, we're all trained in what I like to call the deficit model. Partly, there's some of it that's just out there in the culture, leftover sort of Freudianism bouncing around, that children are born perfect little beings with infinite potential, and then parents mess them up. Now, no evidence supports that because of the interaction of brain and genetics and experiences all nicely braided together. But people's belief and experience definitely supports that. So it must be the responsibility of healthcare providers to correct this process, and often they fail. So this, and behavioral health people, by the way, get trained in find the pathology models or inadequate parenting. We have lots of theories that are just sort of based on the idea of inadequate parents. And yet, if that's the way we're going to conceptualize, we're going to look for problems, and we're going to just highlight the pathology and believe, sometimes some of us believe there's all kind of pathology back there, even if we don't see it. So that is going to make it harder to have relationships with parents that are fruitful. So when you think about something like the ACEs screening and how complex it must be to join a parent to talk about trauma as opposed to blame a parent about trauma, this is hard stuff. This is something we really have to be cognizant of. I find one of the ways of helping that, which fits right into the AAP's mandate for assessing family strengths, is what I would call the asset model. Find the asset model. So think about it this way. Caring for children enriches a parent's life and brings out characteristics in both the child and the parent that otherwise would be unrealized. So often you can get to that just by asking, when do you enjoy this child the most? When do you feel like you have time to really have fun with her that's fun for you, or that's just enjoyable for you? And then anything that the child does well is an opportunity to catch the parent in the act of being effective, and caring. So when the child does something that's conspicuously either excellent or just conspicuously normal in your interaction with the child and the parent, you say, oh my goodness, that's impressive. Did you teach her that, or did she learn it on her own? It's always good to ask questions where the two choices are both complementary. So, because if you taught her that, well, then you're a great parent. If she learned it on her own, well, then you are setting an environment in which this child is growing and developing. And that we, as healthcare providers, are nurturers of this process. So we notice what's special about the child or what is interesting about the child in a way that engages the parents. I used to tell residents when back in the days of paper charts, write on the chart something that's interesting about this child. So you're going back in to see a 9-year-old. If it says on the chart, in some little place, likes dinosaurs, then you get to say, Johnny, you still liking dinosaurs? And when you do that, the parent who's sitting there says, he remembered my child. My child stands out. My child is doing fine. And when they think that, they then think that you, as a healthcare provider, are smarter and are somebody that they would want to listen to and whose advice they might want to take. People are much more likely to take the advice of when we're in an asset model than when we're in a deficit model. This is an example that I put in as a testimonial from a former family medicine resident who was sending this on a email to a listserv of alumni of the Worcester Family Medicine Residency. And he said, so I had a thank you Sandy moment today that I wanted to share. A regular old garden variety inner city kid with challenging behavior, clearly cast as the bad kid, as her mom says all day long. We talked about attribution and made a positive behavior chart. Talked to mom about not paying attention to or talking about the bad behavior in her presence for a while. As we started talking about keeping track of all the great things Kiki does and why she is being good, Kiki came over and sat in her mother's lap and got a kiss from mom. They were both totally on board with tracking desired behavior. And in fact, later we learned that in fact that it had, while everything wasn't better, things were remarkably better when they came back, that it had impacted the mother's ability to feel like she was influencing her child because this had worked so well. So attribution, how you describe people, if you describe them in a way that they believe, it has to be believable to them, is the most powerful way of influencing people when you have no control. If you have control of somebody, well, then control is the most powerful way. But if you have no control, helping them think of themselves as the kind of person who does this or that thing well makes it more likely that they will continue and to do it well and grow in it. So that means you have to do a little of reframing in your language. So a quiet child is thoughtful or self-contained. A rambunctious child is independent or energetic or inquisitive. In general, you don't say that child is normal. You say she's just where she ought to be. She does everything you would expect of a child her age. You do want to check and see what is culturally positive, because there are some cultures in which if you said this child is nicely independent, they would take that as an insult, because a child is supposed to be socialized to being part of a group rather than being independent. So you do need to have a sense of what's positive and what parents would be proud of. When we look at all the things that parents are concerned about, and something on the order of 80% of parents, when they are queried, had some kind of behavioral issue that they would have liked to talk about in a well child check, but often they don't. But these are the things that tend to come back again. So sleeping, going to bed, waking up, all of the issues around sleeping, eating, toileting, playing with other children and socializing, sibling fighting, oppositional behavior, or as people say, she doesn't listen to me, which means not that she doesn't hear, but that when I say something, it doesn't seem to influence what she does. Lying, often parents will, particularly parents who aren't well versed in child development, will look at the 4-year-old who said, I didn't do it, and believe that they are raising a liar and be very upset. That's one of the things you'll help with. Phobias. So being ready to help parents with these issues and having something already put together in your mind about how you would do it makes a big difference. In general, the PCP will be presented with these questions, and you will only be brought in if what the PCP had to say or offer doesn't help with the problem enough. Every now and then, though, the PCP may notice that this is a concern that's going to go on for a while, and they'll bring you in in order to have the longer conversation so that they can go on with their schedule. There was a study done in one pediatric practice where they looked at the day that the behavioral health person was there, and on that day, the practice took in or billed $1,100 more than on other days. Why is that? Because the docs saw more patients, because when they had one of those conversations that was going to be long and go on, the behavioral health person could come and do the teaching or the conversation about the concern. And having a program for that, meaning having a handout for how people might address this behavior, as well as having a meeting just devoted to that behavior, even as a first line of approach, tends to engage people better, because it implies that this is something everybody, or it's commonly faced. On the other hand, you don't want to ask if this handout, you don't want to hand out the handout as if this should answer it, because then that's sort of an insult. If everybody else is dealing with this and it's only one handout away from knowing what to do, feel like I should have known that as a parent. But if you say, would you evaluate this handout? Would you see if this is relevant to you? Because for some people it's relevant, and for some people it's really not. Now they're your consultant, and so they're much more likely to read it carefully and see about using it. Let's talk a little bit about screening. One of the developmental screens that is available, that it's a parent response from 0 to about 5, is called the PEDS, and it is very simple to fill out, and it is very structured in terms of how to respond. And so it's something that's pretty easy to introduce. A little bit more complex is ages and stages, which is focused on development. And the ages and stages, many practices use as a secondary screen. If someone looks like there's a concern on the PEDS, they'll get out ages and stages, because it takes a bit more time and a bit more explanation. Others just use it. That's the screen for every well child check. There's a behavioral screen for ages 6 to 18, the pediatric symptom checklist. And there's now a 17-question version, which is much shorter than it used to be. The screens for specific disorders, autism is the MCHAT now the MCHAT RF, which is revised. I'm not sure what the F stands for, but at any rate, each of these links works and it gets you to that screen. And it's pretty self-explanatory. The AAP and many states require the MCHAT to be given twice in the range of 18 to 30 months. And then the last one is the Vanderbilt, which is the standard screen for ADHD. We'll talk a little bit more about that, but suffice it to say that those who were raised, psychologists at least, of doing long, extensive kinds of testing protocols to assess for ADHD are, that's really not how either the evidence goes or how it's done in primary care. And so being able to use the Vanderbilt, which is a parent and school survey, is going to be part of your job. It's important to remember that when you're communicating the results of the screening, it needs to be done in person. It needs to be done in a way that explains what the screen can and can't do. When you get a positive result on a screen, remember in medicine, positive is bad and negative is good. When you get a positive result, that does not mean that you have identified the disorder. It means that you have identified someone at risk for the disorder, and that any good screen will pick up a lot more people than the folks who actually have that disorder. So you want to be sure you're not using diagnostic terms when all you have is a screen. You're talking about concerns and things we need to look in further and so forth. Often it would help to have a handout about screening and about what kind of resources would be the follow-up to a particular positive screen. And then if the resources aren't within the practice, you want to follow up to see whether folks used it. We need to say a little bit about screening for ACEs. It's fair to say that on the one hand, the evidence of how adverse childhood events, traumatic kinds of events, influence the future of the child in terms of their health, not just their behavior, their health, their use of substances, their cognitive functioning, all of that is linked. And so there's this urgency with, now that people have this ACEs screen, to just screen everybody. You need to have something that you can do, and you need to have something that will engage people in doing that in order to be screening. And so the AAP's material on this is really very helpful, and it talks about the change that has to happen in the practice as a whole, not just in handing out a sheet of paper, in order to assess for trauma and in order to practice trauma-informed care. Also, if you use the ACEs or another trauma screen with a child, once you've done that, you don't keep using it again and again like you might with the PHQ-9 for adolescents and adults, where you're really just talking about a period of time between visits. Once you have an initial screen, you can sort of keep up with how things are going with a one-question screen. And the one question to the child is, or to the parent, has anything really upsetting or scary happened to you or anyone in your family since I saw you last time? And so that keeps you up to date in relation to traumas or challenges that the family's facing. Parent training is a big part of primary care for children. It has the strongest evidence base of any behavioral health intervention for kids. It occurs in a lot of ways. It's not just we have a group. Parent training occurs in the visit with the doc. It occurs in the visit with the behavioral health person. It can occur in the access to materials that people are given. I used to, nowadays things are online, and so having links either on the website of the practice, or having just handout links of websites that you have looked at and that you have assessed for whether this is good information, because there's a lot out there that really isn't. And so you can have links for not only behavioral kinds of things, but links for things like inoculations and why they are sensible and not a conspiracy. So that part of making information available is basic to the job, and often the behavioral health person is the person who looks at all these advanced resources and helps the practice to make the choices, and helps the practice to vet information that's out there, particularly in the behavioral and developmental spheres. Let's talk about ADHD. It's pretty central to pediatric practice. We sort of have to have some approach to it in any pediatric practice. One of the ways to think about diagnosis and treatment of ADHD in pediatrics is that in order to meet the needs of a lot of children, both the usual needs and the unusual needs of children, takes often several organizations in the community. There's schools, there are mental health centers, there are social services, there are churches, there are boys clubs and girls clubs. There are a bunch of folks out there who are engaged in the welfare of children. Every one of those organizations may have something that they do particularly well as part of the services for any given child. They may be the best site. Well, for ADHD diagnosis and treatment, primary care is really the best site, even though a lot of the concerns about ADHD show up in schools. Most schools now are essentially restrained from doing medical diagnosis. And so they can say to a parent, we think you should bring your child to his or her physician for diagnosis and possible treatment, but they can't say, go get him some meds. That doesn't mean sometimes they don't, but mostly they don't, and they've learned. And so the primary care practice can think of that as their role in the organizational network for this child. But you want to have made a relationship with the school or the other organizations in this network before you get this child. In other words, it's part of being in the network, so that you can acknowledge that you will offer this sort of service, but that you'll do it because everybody will do their part. And so with ADHD, the school's part is to fill out the Vanderbilt and to send it in, to be available for conversation with the person who's doing the assessment, to possibly be willing to meet either at the pediatric site or at the school site around what's being found, and that the more that's understood, the more the job of doing ADHD diagnosis and treatment becomes part of this network and not isolating and not alienating between organizations. You will need a protocol. So protocol certainly has a medical history in it. It has a family and social history. Most of that you'll already have. It doesn't mean you now start from scratch. There's a physical exam, including a neurologic exam by the PCP. There's the interview with the child and the parents, and sometimes separately and sometimes together. And there's the screen that goes into thinking about and making this diagnosis. In our practice, we had a 4-visit protocol. And so we would meet with, particularly for kids in the 5 to 12 range, we would meet with the parents first to hear their concerns. That day we would send out the Vanderbilt to the school. Then we would meet with the whole family. You see the kid with the people who are most important to him. You learn so much more than what you learn just seeing that kid alone. Then you see the kid alone, because now the kid has already been to this process with the family and seen the family being comfortable with it. They get more comfortable. They're more likely to work with you. And then you report back to the parent or the parent and the kid, depending on the kid's age. And during all this time, you're doing interventive interviewing. In other words, you're catching the family in the act of doing it well, and you're setting up the likelihood of parent training, because for all ADHD, parent training is a reasonable part of the care, whether or not medication is part of what is prescribed, or what the treatment is. There are special challenges of adolescence, and I'm going to assume that people know something about individual counseling and know something about family counseling that could be useful for adolescents. But there's also, when you're working with adolescents, a new element of confidentiality. And often providers have trouble with that. One of the things that I observed watching particularly family medicine residents work with kids and adolescents was that while there was no need to talk about what we called sex, drugs, and rock and roll, so we don't need to ask this child yet, is she sexually active? Or ask this child yet, is he smoking marijuana? Then the parents there most of the time, they rarely are sent out, or only for specific kinds of issues. But as soon as you need to have those conversations, the child isn't going to tell you with the parent in the room, most likely. And so now it becomes standard practice to ask the parent to step out for certain conversations. At that point, often people make the mistake of thinking that they are, because they are the person that the child admitted that she is sexually active, or that she's worried about sexual issues, or that he's, using drugs or drinking, that the doc knows that and the parents don't, people start to get the idea, the health professionals get the idea that they are sort of closer to the child and that the parents are to be kept at arm's length. The problem is, as I know you know, the parents are mostly what this child has. And that, one, it's important to understand that while adolescents are very good at showing their need for independence, mostly, they're usually not nearly as good at explicitly showing their need for nurturance. But their need for nurturance hasn't gone down much from when they were younger. It's just that nurturance has to be shown a little differently. And that, but they, having their parents, who are their main nurturers, completely excluded isn't helpful for them. I would find that when I would talk to residents about, do you ever ask adolescents if they would like their parent to know the information that they just told the doctor? A very high percentage, particularly higher, much higher than the residents thought was going to happen, would say, yes, if you will help me talk to my parents about this, I will talk about I experimented with pot, or I'm worried about sex things. So the assumption that the health provider conveys in the care of adolescents, that the parents are still important, and that the highlighting of bonding and of influence can be very supportive of and preventative for adolescents. This is a poster that I got. That it's really just to show that there are efforts going on now in New Hampshire about helping support pediatrics. And I put this here so you can have a look at it. And take advantage of some of the services and the teaching and so forth that are being done as part of this process. Also, for people who, this was an orientation, as I said at the beginning. This was not in-depth training for how to work with children in primary care. That's a much larger topic. I'm used to, in our program, we would, at UMass, we would have about a 6-hour element or webinar for working with kids. And you can now access that, that's the second one there, individually. You don't have to take the whole PCBH program at the Center for Integrated Care in order to take that now. But there's also a new training program that's, I think, 40-some hours in pediatric behavioral health integration that's being done through William James College in Boston, but it's online, I believe. At any rate, there's the link that gets you there and that allows you to find out about it and how to join it. I think they've been through it once or twice, and they're just going to do it a couple of times a year. And to further access any of the things that we're doing, there is the New Hampshire Primary Care Behavioral Health Workforce.org. This is the website that our initiative is maintaining. Because we decided to send you the slides, you don't have to go there to get the slides, but in the future, that will be where people can get this webinar. It will be located there